AMREF actually been in Tanzania since the founding of AMREF 1957, but was registered 1967. It established a full-fledged country office 1987. Currently, AMREF has got 19 projects in Tanzania. Some of them have national coverage. Like Angaza Zaidi project covers 23 regions out of 46. And we work with the sub-partners in Angaza Zaidi. The e-learning program also is a national program. We started with 4 schools, but very quickly we have expanded to another 8 schools, the regional schools. And then the laboratory system strengthening program is also covering the entire country, including the island of Zanzibar. And then the national fistula program also have a national coverage. Initially, we used to work with 40 hospitals, but currently we're working with 8 main regional hospitals in the country. The others are community-based projects. We have 10 field offices in Tanzania, Iringa, Mtwara. We have 3 offices in the Lake Zone region, and we also have an office in Kilindi and also in Moshi. Some of our program, like the fistula program, operates about 1,000 patients every year. The Angaza Zaidi counsels and tests about 500,000 people every year. And then we have a lot of training programs. For example, we're reaching about 6,200 community health workers within our community-based programs in the country. And in terms of reach, pure reach, it's very difficult really to get the exact number, but I suspect it's about 2 million people reached or touched by our programs. As you know, AMREF, everywhere, in every country, AMREF works very closely with the governments, the host governments. In Tanzania, it's no exception. We work very close with the government, both at national level and also at regional and district level and community level. As you know, the Tanzanian government is a devolved government. Regional authorities and district authorities actually are semi-autonomous from the central government. So we work with all the layers of the government system. The other partners, of course, the development partners. There's a strong development partner group. We're engaged, for example, through the technical working groups at national level. And also our donors. We engage our donors in terms of field visit. CEDA, for example, the Swedish CEDA. We cooperate with the people in the embassy and also the Canadian CEDA. We consult with communities and engage them at the design of the project and during the entire implementation project time and after the phase out. And communities actually appreciate AMREF in the sense that our approach is actually very special to AMREF, that not many other NGOs approach communities the same way as AMREF does. The biggest challenge is actually too many needs with very little resources. So lack of adequate resources. For example, when you go to community Y, they might want water sanitation hygiene project when you have malaria project, or you're doing HIV programming, but the community priorities are water, hygiene and sanitation. So that's really the biggest challenge in the sense that most of the time, as you know, AMREF is project funded, and each of those projects is very specific to particular intervention. So you really cannot address the wide requirement of the communities and very many emerging needs of the communities. That's the biggest challenge. The other challenge is in terms of the capacity. For example, our biggest challenge in Tanzania is that the health system has huge shortage of health workers. So working at the community level, dispensaries and health centers, the biggest problem actually is the shortage in the sense that there are no skilled, competent health workers to deliver services. So you find you're training medical attendants instead of nurses and midwives who should be the ones who are the frontline health workers. That's the other biggest challenge. The other biggest challenge is actually supplies management. You find that some of those facilities don't have commodities. So the workers in some of those frontline services, delivery points, they don't have the drugs, the medicine, the commodities that they need to implement their projects. So those are really the main challenges. We have identified 3 areas that we need to focus in the next 2 years. The first one is actually building the capacity, internal capacity of our own staff to ensure actually they deliver quality services in terms of project management, monitoring, evaluation, research, and advocacy, which is really the core of our programming to enhance quality. The other area we're focusing on is actually technology, adaptation and application of modern technology, like using e-learning program as an example, but you're also having mHealth, mobile health technology, whereby community health workers can actually track and send alert to pregnant women to alert them about clinic appointments and other things, and also they can also order commodities. The other area is actually looking at mechanism to ensure that we have adequate, diverse funding to sustain the program, growth, and also sustainability for much more longer time. Because currently, as you know, we most rely on projects. So when they come to end, it means we cut those activities or projects have to close. But having sustained funding mechanism, my view, is the only way to sustain the country program.